Hi everyone, thanks so much for joining us today. My name's Ed Smith and I'm the director of the T2D network at the Institute for Health System Transformation and Sustainability, or IHSTS for short. IHSTS is a small BC-based NGO, and for the past several years we've been focused on developing a provincial type 2 diabetes strategy, part of which has been the creation of the T2D network. The network's focused on the prevention, the management and remission from type 2 diabetes, and we're fortunate to have a great bunch of partners nationally that we work with. A core component of the network is education, which is why we're here today. So it brings me great pleasure to introduce Krista Lamb, who's going to be moderating our session today. Krista Lamb is a science communicator who specialises in translating complex topics into interesting and understandable stories for diverse audiences. Her first book, Beyond Banting, was released in 2021 and went on to win the Science Writers and Communicators of Canada Book Award. In addition, Krista has been the producer and host of multiple podcasts, including the award-winning Diabetes Canada podcast and How to Talk About Health. In 2025, she received a King Charles III Coronation Medal from the Royal Canadian Institute for Science in recognition of her commitment to fostering science culture in Canada. So with that, I'll hand this back over to Krista, who will introduce our guest for today. Thanks so much.
Welcome, everybody. I'm so excited to be here with you today for the Type 2 Diabetes Network to talk to Dr. Baiju Shah. So thank you for joining us, Dr. Shah, and I'm going to ask you to introduce yourself and tell us who you are and what you do.
Hi, thanks, Krista, for having me. My name is Baiju Shah. I'm an endocrinologist at Sunnybrook Health Sciences Centre in Toronto, and I'm a researcher and professor at the University of Toronto.
And I'm really excited to talk to you about your research because you do something that's a little bit different than some people in that you do a lot of work to ensure that there is diversity in research. And I wanted to ask you about why it's so important that we have diversity in research.
I think it's really important because we know as clinicians that there's a great deal of diversity in access to care and ability to get care and ability to take advantage of the opportunities that are there for people with diabetes. And so therefore, being able to understand that and analyze that and identify where there are gaps so that we can do something about them, I think is really critical. We see that in all areas of research, but obviously in all clinical areas. But I mean, diabetes particularly, we know affects people who are of lower income, people who are living with other disabilities, people from different ethnic and immigrant groups, Indigenous peoples. So we know that diabetes in particular can affect a lot of populations that may already be marginalized or lacking health equity in other areas. And then the fact that they're also at increased risk for diabetes just kind of accentuates that.
Excellent. And I think it would be really helpful if you explain to the audience what the research you're doing is trying to learn. So everybody always asks, like, well, what is the point of the research? So I try to get that into the conversations.
Yeah, I mean, I think what my broad research program has done over the years is really to try and understand where there are gaps in care for people living with diabetes. So what are the places where people from different groups and different populations have inequities in both in their access to care, but also their outcomes of care, more importantly, like what happens to them compared to the general population or others in the population or others with diabetes in the population. And then increasingly now that we've sort of kind of beaten that drum about that these disparities exist and that there are these gaps, let's now try and work to figure out solutions to close them. So what are things that we can do that can help different populations, depending on the context, achieve better access to care or achieve better healthcare results?
And I often talk about your research when I'm talking to other people because I think some of the things that you've done are really transformative in the way that I think about how we reach people. And I hope that that's been the case for many people that are aware of your research. And I wanted to touch on one particular study that you did with Dr. Ananya Banerjee, which I found so insightful. And I talk about it all the time. And that you were looking at, we have this concept, and I wanted to touch on this one particularly because I know the Type 2 Diabetes Network has a very big South Asian community. And what Dr. Banerjee was looking at was, we say that South Asian communities are more at risk for type 2 diabetes. However, that's a large diaspora of people, and it seems odd that all of those people are at the same risk. And what you found is that that isn't quite the case, that the circumstances are not, are also a big factor alongside, obviously, some of the ethnicity issues. But what would doing something like that, how does doing that type of work help people better understand the need for this type of understanding?
Yeah, well, I mean, I think the sort of first step, I think, in terms of what that shows is that, so whenever we're looking at populations that groups in society or segments of society, we're always going to be lumping together people who aren't necessarily the same, right? And so again, we've often just kind of lumped together South Asians as a group, but that study showed that there actually are differences, that people from India are different from people from Pakistan and are different from people from Sri Lanka or Bangladesh, and that just calling everybody South Asian is an oversimplification. And of course, even just calling people from India would be an oversimplification because there's diversity within India too. And so I think it highlights the fact that you could always go deeper to understand more what's going on in different populations. But it's important to think about where some of those disparities might lie, but to not forget that even within that disparity, there may be other disparities, right? So there are, even amongst South Asians, there's going to be gradients and differences. So that's, I think, one of the most important kind of lessons from that work, is that we shouldn't just paint everybody with the same brush. When we do our work with First Nations communities, there are differences between different nations and between First Nations people living in community versus living in urban areas, for example, or other ways of looking at First Nations people. It's not just one monolithic group. And when we look at lower income communities, it's the same thing. I mean, people's circumstances can be different, and their access to care and their outcomes of care can be different, just depending on the context. So I think it's just important to remember that you're always generalizing, and that it's never as clear cut, it's never as dichotomous, maybe, as we like to make it. But that doesn't mean you shouldn't still, it's still important work. It's still important to think about it. It's still important to recognize that those gaps are there, those disparities are there, but not forget that none of these groups is homogeneous.
And I think it's really interesting because you touch on the fact that you have worked with a number of different groups. You've worked with South Asian groups and Indigenous groups and so many different types of people. Do you have any advice for researchers or healthcare providers that are thinking about doing this work, about how to work with communities that might not be your own, or how to respectfully be a part of research projects that involve communities that aren't your own?
Yeah, I mean, I think that's really, really important. And I think that has evolved a lot in the 25 years that I've been doing this kind of work. I think it's essential to work with the communities and the partners that you are going to be studying, right? Like it's you can't just go in as an analytical researcher or as an academic, descend to do some work on a community and then leave. I think you have to work with the community, understand what their priorities are, understand what research questions they want to ask and they want to answer, and work with them to do that. You're bringing the skills of the research and the methodologic expertise and maybe the access to data or the access to funding and science and so on. But they're the ones who have the lived experience and understand what it's like to be in that community and have diabetes, or be in that community and see where the disparities are. So having that respectful engagement and that back and forth, that quid pro quo, where people are on both sides feeling like they're benefiting from this relationship and getting something out of the work that you're doing together collaboratively, I think is really, really important. If you are from one of those communities, that obviously makes it a little easier because you already have a little bit of understanding yourself. But it doesn't preclude others from getting involved. And I think it's important to not sort of say that only South Asians can do South Asian research or only Indigenous people can do Indigenous research, because I don't think that's also a realistic expectation or solution. Of course, people need to be involved, but it shouldn't be exclusionary. I think we should be trying to support people who want to do good work, even if they're not from that community, but they want to do good work and support that community, that should be encouraged.
Excellent. And are there any things in particular that you've learned along the way from the communities that you've worked with? What have they taught you?
Oh, I mean, I could go on and on. I mean, I think it's really like some of the research ideas, some of the directions we've gone in were things that just hadn't even occurred to me, but we talked with community members or we talked with organizations and realized actually this is a priority and this is something that needs to be addressed. So let's do that. Like the example I would give, I'm an adult endocrinologist, so I focus on diabetes in adults, but when we were doing work with some of the First Nations communities, it was the high rates of diabetes in the children. And that was one of the striking things that concerned the community and concerned the population. I mean, of course, the absolute rates were still pretty small compared to in adults. So that's why it didn't sort of come to the front of my mind. And as a non-pediatrician, like it wasn't something that I was really looking at. But that was such an important thing for the community that we pursued that in more detail and are pursuing that in more detail now. So I think having those conversations to find out what is important is really been one of the most striking things. And I can give lots of other examples where it was just something kind of, I won't say out of left field, but something that I hadn't sort of thought about as the priority. It looked like to me this was the biggest issue, but actually this was the biggest issue. So then we go down that road, and that's fine. I mean, it's not. There's lots of things to talk about and lots of things to study. So there's no downside to changing directions.
I love hearing that, because I think that's one of the reasons that having people, nothing about us without us, sort of as the mantra, because there's so much that we don't necessarily know when we walk into a situation. And for so long, research was done sort of on people and not necessarily with people. And it's been so lovely to see that starting to change. And you touched on something else that I think I wanted to go a little further and more deeply into, which was you talked about lower income. And we often hear the social determinants of health, and that's an area that you work quite a bit in. And so I wanted to ask you, one, if you could define what is social determinants of health, because many people listening might not be as familiar as we are, and how your research touches on that.
Yeah, so social determinants of health basically are conditions, sociological, demographic, non-clinical, non-medical situations that are really important factors in both the development of disease and also the care of patients and the way people are perceived in the healthcare system. And so many of the things we think about are potential social determinants of health. Even basic things like age and gender, sex are social determinants of health. Income levels, education levels, literacy, English language proficiency, ethnicity, religion. These are all things that can be determinants of how people receive care, interact with care, and achieve care in the healthcare system. So they are what I've spent a lot of time thinking about and focusing on, because I think those are places where we know diabetes lurks and we know that gaps in care can exist. And so we want to look at where those are. And, again, there have been times where we've done studies and expected to see gaps that weren't there. So, right, it's not that they're always going to be there, but we do want to identify where the gaps actually are, where the disparities in care are, where the potential for improvements could be, so that then we can work to fill those gaps.
I find this super interesting, and it touches on another area I wanted to ask you about, which was when you're working with people who may be impacted by the social determinants of health, for example, low income, or perhaps they live in an area where there's very poor transit, so many of these things that, they don't really have control over necessarily, but that impact their health. How do we encourage them to get involved in research, and how do we encourage them to share their experiences, because there can be many barriers that they're facing to participation, and so we often get the people who are have the most access to who are participating in research.
Yeah, for sure. And I mean, this is a classic problem, right? It's the people who are most engaged, most interested, most educated already, have the freedom of time, and frankly are probably a little healthier, are the ones who are going to volunteer to participate in research. And this has always been a challenge, right? And we see that in clinical trials, and we see that across all areas of research. I think with this kind of work, you have to be intentional. You have to go and seek out people where they are, go into their community. Don't expect them to come to your academic teaching hospital where parking is $15 an hour. Go to where people are at on a weekend or in an evening when they can find time for you, when they are available, because people want to participate, right? Like I think the misconception is people are just not interested. I mean, I think people want to be involved. They want to help their communities and themselves, but it can't be it has to be easy. It can't be done in a way that's going to put people out or make it difficult, because then, as much as you want to, you can't do that if you've got other things you also need to do. So I think going to where people are, being intentional about finding and engaging with folks. And I mean, compensation is important too, right? And we don't talk about that a lot, but I think granting agencies increasingly are recognizing that as well, that you have to pay people for their time. You can't expect people to just volunteer for these kinds of things. And so it doesn't have to be a huge amount of money. It could just be a token, but people appreciate that. And I think it's important. So that's also become more, and over the last few years, become more recognized as a sort of a legitimate, important research expense that is needed to get people engaged. And I think it's just using networks and using champions. So if you have somebody who you are working with, who you have a good relationship with, who is as enthusiastic about the work as you are, but who has connections in the community, a leader in the community, an elder, a priest, whatever, somebody who is respected and engaged and connected, then, leverage that and get their help to identify people who might be interested and who would be willing to participate.
I think that you touched on so many important things. I always think of my wonderful colleague, Matt, who, when he lives with diabetes and he was experiencing homelessness, and he saw Dr. David Campbell, one of the flyers for one of his research projects, and he was like, oh, there's a $25 honoraria? I can definitely make time for that. And it changed his life, and he has gone on to do wonderful things, but that $25 honoraria was hugely meaningful for him in the moment that he was in his life. And so I think that we often overlook that, we say it's a small amount, but it could have huge implications for the person who is making the decision to participate. So I'm glad we touched on that.
It's even just a signal of recognizing the importance, right? Like that's even it's not necessarily the amount, it's just the recognition.
Exactly. Absolutely. And I wanted to touch again on something else that you said about faith leaders. And you're doing some work right now where you're going into communities and speaking with faith leaders. You're doing some things in workplaces. You're really going to where people are at. And I wanted to give you an opportunity to talk about the importance of those types of projects.
Yeah. So this is some work that I've been doing over the last few years, and it's really about health promotion and getting to where people are at on the ground. So getting out of the healthcare setting, getting out of the doctor's office or the hospital where people come and they, get care, and that's great. But we need to find even beyond that. How do we find people who aren't able to get there, who don't have a family doctor or who aren't sick enough to need to be in hospital? But we still need to find those people. So we've been working with doing some work in workplace health, so doing health promotion in a workplace, and working in faith-based settings where we are doing health promotion activities in temples and churches and mosques and so on, and trying to get the congregation engaged in health promotion, both from a sort of lifestyle behavioral perspective, but also in getting people screened for diabetes and hypertension and getting them connected to primary care if they're not already. So kind of doing both sides of things, the clinical stuff as well as the health promotion stuff, but in a place that feels safe and is culturally relevant and is a place where they're at home, and we are coming to them as opposed to them having to come to us, and that really makes a big difference.
I think all of this is just really going to be very helpful for anybody watching who either wants to get involved in research or is doing research. And so I want to thank you for taking the time. And I also want to ask you my last question, which anyone who listens to me regularly will know, which is there anything that we haven't touched on that you would like to include in this conversation for those who are watching or listening today?
No, I think I would just reiterate that what I've said, that this is important work to be able to understand and help close some of those disparities for people who, as you said, these social determinants of health are not things you can necessarily change or do anything about, but they impact your health and they impact your ability to get care. And so it's important to be able to address those and figure out ways to break down some of those barriers so that all of us can have equal chances at success and health.
Wonderful. Well, thank you so much for joining me today. This has been such an incredible conversation, and I appreciate it so much.
Thank you. Nice to see you again.
Excellent. And for those of you who are watching or listening, we'll have more information in the show notes below, so you can find out more about this conversation. You can also find out more at the Type 2 Diabetes Network's website at t2dnetwork.ca. Thanks for watching.